There we go. God, I hate that photo.
Oh.
What are you talking about?
That looks so terrible. I'm sorry.
Beck has one, and it's on a big pull-up banner that we use when we're at practical workshops. But she's only got one earring in.
Oh, yes.
And I never noticed. I always just saw this beautiful poster. And then she said, I'm only wearing one earring. And now that's all I can look at whenever I see that.
One had fallen out and I hadn't noticed. I was, they said, oh, we need a photo. And I tried to make just Mike take a photo of me holding the cat, and noticed that afterwards. It's a fashion statement.
Yeah.
I'm sure that's something easily photoshopped, though, really. I mean, you just put dot.
Good
I
point.
couldn't, I'm sure someone could.
We might take a Sharpie next time and just
Just one in.
Oh dear.
No.
Who's sharing at the moment?
It's me.
Oh, you. Okay.
Cool. Cover page up, and then I think we'll just maybe give people another 2 minutes and start maybe 1 minute past 8. Oh, not 8. 12.
So can only one of us share at a time?
Yes.
Yeah. Okay. Cool.
So when I've finished doing the intro bit, I'll just stop my sharing and hand it over to you.
Cool. We'll try not to yawn.
You feel free to. It's very late.
It's okay.
Yeah.
So good.
All right. Get started. I think we may as well. I mean, if we've got any who are coming slightly late, they can join in. So, hi everybody, and welcome. Thank you for joining us again today. For those of you who don't know me, I'm Dr. Rebecca Waite. I'm one of the vets with Vets for Compassion, working with ACTAsia, delivering vet training in China. And we're really delighted to bring you the next in our series of webinars that we've been running over this year. And this one's on dental examination of the dog and cat with Dr. Marcella Cassiani Lowe. We'll have a lecture around about an hour, and then we'll do a question and answer session afterwards. So if you've got any questions as we go along, if you could type those into the chat function, and we'll pick them up at the end. Please do ask questions on anything you would like to. It's good to have lots of questions, and we love answering those. So fire away, and we'll get to those at the end of the session. If you could also just take the time, please, to check that you have muted your microphone during the webinar. Otherwise, we'll be able to hear everything that's going on in your world, and that may or may not be a good thing. So make sure you click mute. And also, if you haven't managed to find it, down the bottom of your screen, there should be a little globe which you can click and choose either English or Chinese to hear the presentation in today. Lastly, at the end of the session, I'll pop this QR code up again. It'd be great if you could go through the QR code and answer our little questionnaire. That's really helpful for us when we're designing future sessions. So moving on to our webinar, I'm going to introduce my colleague Marcella, who has worked with me at Young Vet Centre for I think 6 years now. So that's a fair wee while. Marcella was born in Boston in the US and moved to New Zealand to study at Massey University in 2004. And in her second year there, she had a couple of two life-changing events. She met her to-be husband, a Kiwi, which I guess is one of the reasons you wanted to stay here, Marcella, and also discovered a secret passion for veterinary dentistry when she spent time back in Boston doing an externship. She graduated from Massey in 2009 and decided to make New Zealand her home, which is lucky for us. She worked in a variety of clinics in our local region of Canterbury, honing her skills in all things dentistry, doing a stack of continuing professional development. And in 2016, she became a member of the Australian New Zealand College of Veterinary Scientists in Veterinary Dentistry, and now spends 3 days a week providing a comprehensive veterinary dentistry service at our clinic in Rangiora. When she's not at work, she can be found spending quality time with her husband and 2 small children, tending to her rather large and growing collection of pets, or riding her horse around our beautiful countryside, which we're very lucky to enjoy. So without further ado, I'll hand you over to Marcella. Thank you.
Cool. Thank you, Rebecca. Now I'm just going to see if I can get my video up here. There we go. Share that. Right, get this up here. Cool. Thanks for having me, ACTAsia. This is really quite a privilege to be able to do this and share this information with everybody tonight. I thought tonight we would cover the dental exam of the dog and cat. So what I will do is we'll just get started. How can I get you to there we go. Wonderful. So to get started, this statistic gets thrown around quite a lot, but really it's something that's important to remember. 80% of patients who walk through your doors in the veterinary clinic have some form of dental disease by the age of 3 years. If we were to include animals under the age of 3, that number would increase easily to about 90%. So it is a very, very common thing to see. It's also, you know, dental disease is something that absolutely has a direct impact on the animal's quality of life and can be quite a painful and uncomfortable condition, which leads to it being quite rewarding to treat. You know, I get asked quite a lot why I like dentistry so much, and one of my top answers is that once we treat the disease, the animal comes back usually, you know, about a week later for their post-op check, and they feel $1 million, and the owners really notice the difference. So it's really quite rewarding when you are able to recognize what's normal and what's not, and then proceed to understand how to treat it. So tonight, what I thought I'd cover in 3 different categories, I thought we would start with what exactly is a comprehensive oral health assessment. So we, you know, sort of shorten that to a COHA. Also, we're going to talk about recognizing the 4 stages of periodontal disease and a brief rundown on what periodontal disease is, how it's caused. And then to finish, we're just going to talk about 5 common dental conditions seen in general practice. Of course, there's many more, but I thought, you know, these are some that you'll quite probably very often see in your day-to-day work as GPs. So a comprehensive oral exam, you have 2 opportunities to examine an animal's mouth, one when they're awake and one when they're anesthetized. And it's extremely important when you're communicating to your clients what the limitations are in the conscious patients, particularly if they're aggressive or not particularly cooperative, versus the anesthetized patients in which you will be able to fully complete your exam. You know, I made a little note there, probing, x-rays, and cleaning. You know, of course, they must be done under general anesthetic to get the full picture. So when you're examining the awake patient, in your mind, it's good to have a little bit of a list of what you should be looking for. So the extraoral exam, so without even putting your hands on the animal, you know, the first thing you can look at are things like facial symmetry. You know, are there any swellings on one side of the face or the other? Or is there muscle loss on the top of the head? You know, those sorts of things. You know, are the eyes bulging? Is one bulging out or the other? And understanding the differentials for that. The other thing is halitosis. I mean, oftentimes some of these animals, particularly ones with quite advanced periodontal disease, that you can smell them before they come in the room. And then, you know, you start to put your hands on the animal and you start palpating. So looking for you know, palpating lymph nodes, your mandibulars, your retropharyngeals, if they're asymmetrical, if they're enlarged, painful, looking for nasal discharge, and looking at the lips. You know, are there any swellings? Or, you know, some animals will, for example, you know, if they have an issue with missing a top canine, the bottom canine might be catching the lip, causing lip entrapment. That can be a painful condition for animals. Intraoral exam, this is when you actually lift the lip and you're looking inside the mouth. This is where you're going to be looking at the degree of gingivitis and tartar. You're going to be looking at occlusion, so the relationship between the lower jaw and the upper jaw, and how the teeth sit in the mouth, and whether or not that might be uncomfortable for the patient. Looking for fractured teeth, looking for missing teeth, looking for enamel abnormalities. Is there enamel missing? Do the teeth appear discolored? You know, is it discoloration because they're covered in tartar, or is it discoloration coming from within the tooth to indicate endodontic disease? And then when you anesthetize your patient, this is when the real business starts. This is when you can fully assess the mouth and actually determine the extent of the disease. This instrument here it should be the cornerstone in everybody's dental kit. It's a probe, basically. You've got this end here is the periodontal probe. So it's a blunt-ended probe, and it has individual little markings on it, which indicate, each line indicates a millimeter. And this is used basically to probe the gum line, and every tooth should be probed. And in dogs, you know, a normal probing depth in those gums should not be more than 3 millimeters. You know, commonly, particularly smaller breed dogs, it should only be 1 millimeter. And in cats, you know, you're looking at 0 to 1 at best in a normal mouth. On the other end of your probe, you've got this sickle-shaped sharp bit, and that's basically your explorer. You know, human dentists use it to look for cavities. What we use it in veterinary dentistry is to look for exposed dentine. So if you have some missing enamel or abnormal enamel, you use the sharp end of that to see whether or not you've got exposed dentine. We'll talk a little bit more about that later, and the implications of that. Dental x-rays, now this is, it's absolutely worth talking about. It's definitely a whole nother topic for another night, but you know, you cannot practice dentistry without radiography. It's just impossible to make all of your decisions without looking under the gum line. 70% of the pathology in the mouth is under the gum line, and you will miss things without radiographing. And of course, that must be done when the animal anesthetized. And then of course, you're going to do your subgingival and supragingival ultrasonic scale and polish, which is, you know, that's the thing the client sees in terms of, you know, you can take your before and after pictures. I'll have a couple of those later on in the presentation. And that makes it a very visible thing to your client. They can see, oh my goodness, I didn't realize how much tartar was accumulating on my animal's teeth. So that's quite satisfying as well. This is just an example of what you can do once you've done your exam, both external while your animal's awake and internal once they're asleep. You can actually record it on a chart, and that's highly recommended, both for your purposes. It makes it a lot easier to refer back to write your records, but also you can take a photocopy of this and give it to your clients, and it's really helpful. It doesn't have to be complicated. This one, of course, is for a dog, and there's plenty of templates around on the internet. A lot of pet food companies, I believe this one is sponsored by Hills or Pfizer, you know, all sorts can provide you with a template for a chart, and it's really quite a nice, again, visual thing to show your clients and say, hey, look, you know, your pet's not just coming in to get their teeth cleaned. This is what we found. You know, there's a pocket here, there's a fractured tooth here. And it just provides a nice summary of what you found. So talking about recognizing the normal, of course, it's always important to start with to know what is normal. And so in cats, it's good to know that in a normal feline, at 30 teeth total is what you should be finding in a normal mouth. The numbers I've put here, so maxilla, your top jaw, 3-1-3-1, what that means is if we split the mouth into quadrants, so right now we're looking at the upper left quadrant of a cat's skull, 3 stands for 3 incisors, 1 is 1 canine, 3 is 3 premolars, and then 1 is 1 molar. So it's just a little formula, 3-1-3-1, you can remember in each quadrant up top. Down the bottom in the mandible, it's almost the same, except instead of 3 premolars, you only have 2. And so you have 3 incisors, 1 canine, 2 premolars, and 1 molar. And it's quite important to understand that anatomy. In dogs, you should, in a normal dog, there should be 42 teeth. And again, with our formula, splitting it into quadrants, it should be 3 incisors, 1 canine, 4 premolars, and 2 molars up the top. On the bottom jaw, again, it's 3 incisors, 1 canine, 4 premolars, and 3 molars. And the importance of this for both cats and dogs is when you're doing your exam and you're looking in their mouth, looking for missing teeth can be quite important. You have to ask yourself, why is it missing? Is it missing because it never erupted? Is it missing because it never developed? Did it fall out? Was it extracted? And this is where dental radiology can come into play. Talking about occlusion, this is really important again. So when you're opening up that mouth and having a look, this is something you can certainly see in an awake animal if they're amenable to being examined. You know, effectively the definition, this I retrieved from the American Veterinary Dental College website because they have a really lovely comprehensive reference material that you can easily visit, avdc.org. And occlusion they define as basically the relationship between the maxillary and the mandibular teeth as they come into contact when the mouth closes. So this is considered normal. It's a scissors bite. You look from the front and the top incisors should be just gently overlapping the bottom incisors. The lower canine should be sitting just between the 3rd upper incisor and the canine. In that space there we call the diastema. Looking at it from the side, looking at it from the side, you can see again, you know, that lower canine sits nicely in between the 3rd incisor and the canine, but you look at the premolars from the side and you get this lovely zigzag appearance, and that is what you really should see in a normal dolichocephalic dog. There are 4 classifications of malocclusions. I've kept this very simple, and it is, I feel, something quite important just for documenting purposes, because there's a lot of layman's terms that we use, which can get confusing and sometimes can be incorrect just from misunderstanding between veterinarians and also with owners. So worth talking about the 4 different classes of malocclusions, and also whether they're traumatic or atraumatic. And what that means is, traumatic means it's an uncomfortable, it's a painful malocclusion and something needs to be done about it, versus an atraumatic occlusion, which means that, you know, the teeth don't sit correctly in the mouth, but it's actually not causing any discomfort to the animal. So with a class 1 malocclusion, the jury is out at the moment whether or not this is genetic. There are some, for example, in this picture, this is most certainly a genetic malocclusion, but basically you have a normal rostrocaudal relationship of the maxillary and mandibular dental arches. So when you look at the front, your incisors are sitting appropriately, meaning, you know, your mandible and your maxilla are the same appropriate lengths, but you've got one or more teeth that are out of place. And so in this dog has a condition called Lance canine, whether or not during development he suffered some sort of trauma, or whether that lower canine pushed up on that tooth and it was already pointed in the wrong direction. Very likely this dog will need correction of that. Class 2, this is where you start getting into the high likelihood of them being traumatic, so very painful, causing trauma to the mouth. This is where your mandible is shorter than your maxilla. Some people refer to this as undershot jaw or parrot mouth. Simply calling it a class 2 is sufficient for record keeping purposes. And quite commonly the sequelae to having a malocclusion like this is, you know, in this dog's mouth, invariably those lower canines are digging into the soft tissues in the palate. As well, even you can have these incisors digging in, and it's really uncomfortable. We often see them as puppies. You often get reports from owners that these dogs are really hard biters and chewers, not biting out of aggression, more biting out of frustration when they play with their toys or with other dogs. And if left untreated, you can actually develop something called an oronasal fistula. So these canines, as they erupt, they can actually erupt to a point where they penetrate the palate, creating a communication with the nasal cavity. And that's, we don't want that. We try to prevent that where possible. So that's your class 2 malocclusion. Class 3 malocclusion, this is something that is, I guess you could say, accepted, you know, in our brachycephalic breeds, hence why I've got the picture of the bulldog there. And they may or may not be traumatic malocclusions. These are essentially where your mandible's longer than your maxilla, or overshot jaw, as some people like to call it. I've put in a picture here of a case, and this is very, very common, where the upper incisors will actually traumatize the lingual mucosa here just behind the lower incisors. So of course, this is the lower jaw. These are the 2 canines, and this is the incisors. And this has been going on for quite some time. You can see there's been almost like a clamping effect. So every time this poor dog closes its mouth, those teeth are digging in, and that's really uncomfortable for this dog. So the treatment of choice, of course, is to extract those incisors, any of which are causing the trauma. Now, this is quite extreme. The dog on the right, I think, suffered quite serious facial trauma, but this is just showing a class 4 malocclusion is quite serious, because this is, you basically have asymmetry in several different directions in the mouth. We sometimes used to refer to this as Rybite. The American Veterinary Dental College sort of prefers not to use that term, as it's not very specific, but you know, these are the cases where, you know, invariably there's going to be trauma from either teeth to soft tissues in the mouth, or enamel on enamel, so upper teeth and lower teeth hitting each other inappropriately and causing discomfort. So really important to recognize this on your simple day-to-day annual health exams, animals that come through the clinic. What have we got next? Talking about some normal periodontal anatomy. So this is in a single-rooted tooth. So of course your canines and premolars, incisors, things like that. Worth mentioning, so what we've got here, this is from this tip to here is your crown, and then from about this level where the gum starts right up to here is the root of the tooth. Simply put, you start from the outside. We've got this thin layer here of enamel. Just inside your next layer is dentine, and this is your porous layer. When you have exposed dentine, this is where we can run into problems. The pores in dentine are big enough for bacteria to enter and cause infection. So we'll talk a little bit about enamel fractures and fractured teeth a little bit later. This line in the middle, this is your pulp canal, and within that is your blood supply and nerve supply to the tooth. And at the top here is something called your apex. Within that, these little fronds are your what's called your apical delta, and this is where the blood supply of the tooth communicates with blood supply outside and within the jaw. Around your root, you've got a material called cementum, and here the cemental enamel junction. Sometimes you might be able to visualize this if you've got a patient with quite severe gingival recession. So worth knowing, you know, you can identify the difference between enamel and cementum, and the texture, which, you know, enamel's nice and smooth and cementum has quite a rough surface to it, and it's really a nice surface for plaque and tartar to settle on, so we don't want that exposed. surrounding your root, you have the periodontal ligament. So this is basically a soft tissue that holds that tooth into the alveolar bone, which is the surrounding bone around the tooth. So when we refer to periodontal disease, we are referring to disease of the tissues surrounding the tooth. Perio meaning around, and dontal, tooth. So the ligament, the alveolar bone, and the gingiva. Not too much different with a multi-rooted tooth, but it is worth mentioning here. When you've got a tooth with more than one root, this bit here called the furcation is something important to know about and identify. You have some animals with advanced periodontal disease where you actually will have furcation exposure. And if you have basically any more than second degree furcation exposure, I'll explain that in a minute, the tooth needs to be extracted. It indicates there's been far too much alveolar bone loss. So there's 3 levels of furcation exposure. You use your dental probe to examine that. Basically you stick your probe right here, and if it just blips into that furcation, it's a grade 1 furcation exposure, which is, you can clean that pretty thoroughly and hopefully get a little bit of reattachment. If your probe goes in and not completely through to the other side, but about halfway through, that's second degree furcation exposure, and that's indicating that you've got some advanced disease. And then third degree furcation exposure, of course, your probe will go all the way through, and that's just, there's no saving that tooth unless you have an extremely dedicated owner that's willing to get a perio brush in there, but the ethics of that is a bit questionable. Right, I have a little video to show you. It's a 2-minute video that talks about the pathogenesis of periodontal disease. I thought it was quite a good little animation. What I'm going to do is just stop share for a second and bring that up for you. Let me find the video. Where are you? There we are. Okay, so I bring back the, where are you? Sorry, bear with me for a minute. Okay. Sorry, bear with. I'm going to share again. And okay, bring that up. Sorry, bear with me. Oh. Can you guys see this? No.
No.
Okay, here we go. Hang on a minute. There we go. Sorry about that. Oh, goodness me. There we go. Okay.
Yay.
Got it. Wonderful. All right. Can you play for me? That's just quite a good little rundown. Let me just go back. Hang on a minute. Back here and come up here. Oops. Share again. Here we go. Coming back. Cool. So that's just a little rundown. It's just kind of a nice little animation to get you pumped, hopefully, to have a bit more of an understanding of periodontal disease and you know, how serious it actually can be for animals. Now let me just pull this up. You want to come up for me? Hang on a minute. Why isn't it working? Hang on a minute. Oops, sorry. My computer's having a meltdown. Okay, sorry, my computer's frozen. Can you guys hear me?
Yeah, we can hear you, don't worry.
You can hear. Uh-oh, okay, sorry.
Don't worry.
It's having a meltdown.
It can't cope with playing a video and doing a PowerPoint at the same time.
I can't believe you made me do that. Hang tight. Oh dear.
Do you want to try stopping sharing and then starting it again?
Yeah,
and
let me just see if I close. Let me close that down and see if it's happier with that. Yeah, let me try that again. Hang on a minute. Here we go. Let's see, will that help? Oh dear.
Okay. Another option might be for one of us to put your presentation up on our screen, and then if yours is completely decided to freeze, we can just skip slides when. Or do you want to try closing it down completely first?
I'm trying to, yeah. Let me just stop share. Sorry, guys. Hang on a minute. Oh, okay. It's when I share it, because I can, when it's on my computer. Hang on a minute. Oh, bum. All right, hang on. Let's try that. There we go. Now it's behaving. Thank you. Sorry about that. All right. Yeah. Right. So where were we? So the video basically ran you through the pathophysiology of periodontal disease. Put simply, it's a plaque-induced pathology of any part of the tissues that hold the tooth in the mouth, which we said before. We were talking about the basic anatomy. So at the end of the day, plaque is our enemy, and we want to basically prevent plaque accumulation where possible. When we talk about periodontal disease, we split it into two clinical conditions. One is gingivitis, and two is periodontitis. Gingivitis can be reversible, whereas periodontitis is not. There are 4 stages of periodontal disease. Stage 1 is early gingivitis, and this is reversible. So if you detect gingivitis, these animals don't necessarily have to have any visible plaque, visible tartar on their teeth. But these are the animals you want to get in and do a scale and polish, or start implementing some dental home care recommendations. Again, a topic for another time. Stage 2 is when you're starting to get advanced gingivitis. I've got some real-time photos to come shortly on this, but this is just a good little chart rundown, something worth having handy in your consult room, so you can point to where the animal lay in the chart for your owners, so they can have a better understanding of what you're seeing, and getting them to see what you know, where their animal sits. You know, when you're starting to get into stage 2, quite often the analogy I use with my clients is, hey, you know, if this was your kid and they were brushing their teeth, they'd be spitting blood into the sink. You know, this is when you've got quite serious gingivitis. You know, if you've got the animal asleep in front of you and you start probing with your periodontal probe, those gums are going to bleed straight away. They're going to be painful. And you're going to have these animals, you know, a lot of them have bad breath. You know, the bacteria in the mouth, when it basically breaks down the tissues, it creates these volatile sulfur compounds, and that's the nasty smell we smell when we you know, can smell these guys walking in the room, basically. Stage 3 is when you then move into periodontitis. So stage 2 is your gums are only affected. Stage 3, now you're starting to have the tissues surrounding the tooth, the bone, the ligament. You know, they're starting to be affected, as well as the gums. And, you know, you can sometimes see pustular discharge. You will possibly even visibly see slight to moderate bone loss. You might see furcation exposure, like we talked about before. You know, and then we move on to stage 4, and these are the animals, you can almost smell them before they come in the room. We affectionately call these guys sewer mouth because they're just so heavily diseased. This is a welfare issue. My goal, personal goal, and most dentists, I think, personal goal, is to avoid seeing these come in the door. We want to see them more at stage 1 and stage 2 and start preventing, rather than letting these animals get to this point. You know, and that said, it's still going to happen. And when these animals come in, quite often these are the animals we know they're going to have multiple tooth extractions. When communicating this to my clients, you know, a lot of clients, they might get a little bit worried about the number of extractions and how is my animal going to eat, and they ask all sorts of questions like that. And you basically tell them, look, you know, your animal's probably not chewing right now. It's probably too painful. And, you know, it's better out than in when you have to extract that many teeth. And this poor dog, you can see in this picture, top is the before and after. This dog lost quite a lot of teeth due to advanced periodontitis. So this is the American Veterinary Dental College staging of periodontal disease. Stage 0, effectively, these are your normal patients. And I have to say they're a rarity. You know, I had to search high and low in my own stash to find photos of normal, because most of mine are abnormal. So these were animals that had come in for spay and neuter. And it's important, you know, these animals that come in for other, you know, other procedures, you know, I get picked on a little bit because if an animal is asleep or something else, I'll go and have a quick look under the lip. But you often find things. And in this case, I didn't, which was great. So this cat came in for a spay on the left, and she had normal mouth, which was lovely to see. No gingivitis, no tartar, and no visible plaque. The dog on the right, of course, that was a dog came in for a neuter, and lovely young dog, beautiful white teeth, no gingivitis. So that's what we're aiming for. This is the stage 1. So this is when you start to see a bit of inflammation taking hold. You can see there's visible plaque here. You know, this sort of yellow discoloration, you're starting to get tartar. Plaque itself isn't necessarily visible, but in large accumulations, in large quantities, you will see like a furry appearance to the tooth. You can see a feathered appearance to the gum here in this dog, and that's early gingivitis. That's a gum that's starting to get really quite angry. And in this cat as well, it may look quite subtle, but you are getting that rim of gingivitis over these teeth. So this cat needs to have, you know, some form of dental home care implemented. Stage 2, this is when you are starting to get more advanced gingivitis. You're starting to get, you know, the periodontal tissues affected. When you start probing these animals, they bleed quite readily on probing. You can appreciate, this is a before and after of a greyhound I did. I believe she was about 5 years old, so not very old. But you know, you can appreciate down here, she had this rim of tartar, and you know, even just to clean it, she still had some residual blood because those were quite irritated gums. So quite lucky we got in there when we did, and probably slowed that periodontal disease quite a bit. We cannot reverse it. It's really important to communicate to your clients. You know, yes, we've cleaned the teeth, they look beautiful, white and shiny, but it is progressive, and it is something that we need to keep on top of. we cannot cure it. This is a cat. This was an 11-month-old cat, so quite surprising, you know, falls outside that 80% statistic that we talked about at the beginning, but this is a cat with something called juvenile gingivitis, and it's something that commonly happens as the baby teeth fall out and the adult teeth erupt. They get this condition, and it can be quite uncomfortable for these cats, and they require a bit of management. These gums, as soon as you touch them, they bleed quite readily. And for an 11-month-old cat, you know, that's quite a lot of, you know, tartar starting to build up on that lower molar there. So, yeah, really important to lift the lip in these animals, young and old. Stage 3, this is when you're starting to get that earlier periodontitis. You're getting that moderate calculus, you know, loss of attachment. This is when you're really going to start to talk about extractions with your clients. You know, we start talking about probing for pockets, you know, so we talked about the normal probing depths for dogs being between 0 and 3. This is when you start to get greater than 3, so 3 to 5 millimeters is what shows up on your probe. In cats, you know, a 3 millimeter pocket in a cat is quite significant. So that's some serious periodontal disease starting. And this cat here, this was a photo that sort of a photo series that I had to show to an owner. She wasn't very convinced that her cat needed much done in her mouth. So I took these photos to show her, and on the left here, yeah, you can appreciate, I had already probed it prior to taking the photo, and it was a bit bleedy and sore. But when I stuck the probe in, you might be able to appreciate this little bulge right there. That's the tip of my probe. So it went in, that's about a 4 millimeter, 5 millimeter pocket in that cat. So luckily the owner, after having seen these photos, she was convinced. So don't be afraid to take photos for sure. It helps a lot in your client communication. This is a dog. This was a 3-year-old Shih Tzu, I believe. Whoops. And looking at it from the side, you know, this was a dog that wasn't terribly easy to examine when she was awake. And so you look here and you kind of go, okay, 1, 2, 3. Oh, there's one missing. Oh, hang on a minute, what's going on here? We look from the front, and this little guy is actually crowded right in there. And so, you know, this dog has quite advanced periodontitis for its age even, and she required quite a few extractions to get her mouth comfortable. But you can appreciate the tartar accumulation, and these are quite inflamed gums. You can even appreciate the border of her tongue had become irritated from the level of disease in her mouth. And then stage 4, this is the end stage. Huge deposits of calculus, quite common. You'll see the calculus bridging across teeth, severe pocket depths, lots of mobility in the teeth, lots of furcation exposures. This is the end for a lot of teeth. And you know, these are the ones we really want to try to stop seeing. You know, getting them in earlier. These, quite frankly, these break my heart. They come in and you think, oh, if we'd only had the dog in, you know, 5 years earlier and got them onto a bit of a dental health care plan, you know, the favors we could have done for it. And same with this poor kitty over here. You know, that's a lot of tartar on that cat's teeth. It's going to be super uncomfortable for it. This was just an aside, an interesting one of a dog that really from about this premolar up had quite nice teeth, and it was quite an aggressive dog, so we couldn't actually look in its mouth until it was asleep. And you know, the dog was kind enough to bare its teeth enough at us in the consult room to see that, oh, hey, look, it looks pretty good up here. It could be just a scale and polish, just a scale and polish. Got the dog asleep, and sure enough, there was really severe gingival recession on this upper 4th premolar, and it ended up that this tooth literally just plucked out, you know. And for you to be able to take out a 3-rooted tooth without raising a gingival flap and burring away bone is significant. So this is just an example of localized advanced periodontitis. The rest of his teeth were fine, so that indicates that dog probably traumatized that tooth at some stage in his life. What did I say? So yeah, any patient considered stage 2 or above, you really should get them in. and at least offer them, you know, a subgingival scaling, polishing, a full exam, x-rays. You know, there are patients that require, you know, as frequent as 6 monthly dental prophylaxis, you know, dental scale and polish. You know, there's only so much an owner can do at home. You know, if you've got a really diligent owner and they're doing everything, they're brushing their teeth every day and they're offering them chews and giving them the diets and all sorts of special sprays and gels, they're only ever going to get 70% control. And I do often use the analogy in human dentistry that, you know, we're meant to be brushing our teeth and flossing twice a day and still going to the dentist once a year. One analogy as well that I recently learned in a webinar I did, that I am now using quite a lot too, is when we talk about, for example, with dogs, you know, 1 year of a dog's life is equivalent to 7 years of a human's life, and that's based on tissue maturation and an eventual degeneration. So if we put it into perspective for our clients, 1 year of a dog's life without having any dental home care, particularly if periodontal disease has already taken its hold, that's equivalent to us not brushing our teeth for 7 years. And so 6 months may be a little bit better, but it's still 3.5 years without brushing your teeth. So starting to put that into perspective with owners has really helped them to understand that, yeah, it might seem frequent, but it's actually, you know, bare minimum really for some patients, particularly your smaller breed dogs that are more prone to periodontal disease. And, you know, quite often you'll also, you will get the other side, you know, clients will say, oh, but he had a dental 3 years ago. And so we're trying to shift that mentality and saying, hey, you know, this is a progressive disease and it's actually a welfare issue. You know, it becomes really uncomfortable and it's difficult to convince clients because a lot of times, you know, they're not convinced. The common rebuttal I get when I tell an owner that their dog has quite severe periodontal diseases, but he's still eating. And, you know, I have to kind of quietly say to them, well, you know, he'd rather survive. You know, it's a case of if he'd rather not eat and starve himself to death, then that's a serious issue. And so it's really important to communicate the importance of this to your clients for the animal's welfare. So finally, just chatting about some common findings in the oral exam. Most of which you could see on the awake exam. So it's interesting to at least look. So the first one we're going to talk about is persistent deciduous teeth. Now, persistent meaning that they're still there and they haven't gone away. So obviously deciduous teeth equals baby teeth. So these are the first teeth that develop in a puppy or a kitten. We expect these teeth to shed round about the age of 3 to 4 months, depending on the breed, depending on, you know, various environmental factors. But that's about the average timing. So when we refer to a persistent deciduous tooth, it's basically one that stayed in place despite the eruption of its permanent counterpart. And I have a little rule of thumb, you know, at work where basically if you have 2 teeth of the same type in the same place at the same time, you've got to get one out. Within 2 weeks of that persistent deciduous tooth being present alongside its permanent counterpart, you can actually get quite serious periodontitis developing to a point that you can actually compromise the permanent tooth, and it may require extraction as well. So it's important to pick these up early. Quite often, you know, if an animal is in for a spay, for example, cats, you know, we'll just quickly take out the deciduous teeth alongside the spay procedure. We don't want these guys sticking around. The other sequelae to allowing these teeth to stay in place is they can cause malocclusions, so they can actually interfere with the eruption path of the permanent teeth. And, you know, one common presentation of that is, you know, the bottom canines of dogs. If that baby tooth is in place, the baby tooth generally are on the outside and the adult teeth erupt inside those teeth. And if the baby teeth haven't shed, those teeth are going to erupt inappropriately and potentially cause a lot of discomfort. This one little dog is a good example of that. This was actually how old was he? I think he was about 3 years old. He was a little Pomeranian mix, and he had a whole heck of a lot. And you can see how the tartar that's accumulated. So this poor little fellow, of course, we took out all of these. These are all his baby teeth here. This is a baby canine here, baby canine here. This is a baby deciduous premolar cap that stayed in place. This was interesting here. This guy had some genetic issues, but this was a permanent looking deciduous tooth that never actually resorbed its roots. And so he needed quite a few teeth out, the poor little fellow. So unfortunately, we hadn't picked it up earlier. Next, we're going to talk about fractured teeth. The main take-home message with fractured teeth is if you see one, it must be treated immediately. These will invariably develop infection at some stage. It can happen within weeks, it can happen within months, it might not happen for years, but it is uncomfortable. So initially when a tooth fractures, it's sore. On the left here, this is what the ABC classifies as an uncomplicated crown fracture, meaning the pulp is not exposed. You just have exposed dentine. On the right here, you have what's called a complicated crown fracture, which means you have exposed pulp. So that little dot in the middle is your pulp canal exposed to the wide world. Either one of these teeth, you have a very high likelihood of developing, for example, root abscessation, probably quicker in this guy because you've got your pulp open to the elements, to the bacteria, to the saliva. But both are painful. When you expose this dentine, this is a porous surface. And there's osmotic pressures that occur once you open up that porous surface. Basically, there's an osmotic effect. And so the saliva and the fluids from the mouth are sucked into the porous holes of that dentine, and along with it, bacteria. And commonly you will see, if you x-ray these teeth, you will see endodontic disease. And, treatment for these, there's really, in these chronically fractured teeth, it's either going to be, if you know, and you're lucky enough to know someone with the skills to do endodontics, you can have them have a root canal or extraction. There's really no wait and see option. Causes of fractured teeth, the most common is trauma. They've been accidentally hit with a cricket ball, or kicked in the face by a livestock animal. We see a lot of horse versus dog, or cat fight injuries, and oftentimes the teeth are victims of it as well. Chewing on inappropriate objects such as bones, rocks, and sticks. It's worth mentioning, the enamel on these animals, dogs and cats, is actually really thin. And I say this to my clients because we think these animals have been designed to grab and to rip with these teeth, but actually, the enamels can be anywhere from 0.1 millimeter to 1 millimeter, whereas humans have, upwards of 1.5 millimeters. So we actually have thicker enamel than these animals. So, dogs in particular, with the whole hot topic of feeding them bones, I try to steer my clients away from allowing their dogs to chew on bones, and absolutely no chewing on rocks and sticks. But I'll show you some photos of some really common fractures here. All these two here were both caused by bones. This was actually the same dog. This was the obvious fracture. So this is his upper fourth carnassial. And I think what had happened, he had been fed a large bone, and he was just left to it, and he chewed and chewed and chewed, and he got a slab fracture. So there was no hope in saving this tooth. It was extracted. But we also, in passing, with the periodontal probe, another reason why it's important to probe, we discovered that there was also a slab fracture here on this bottom premolar. Very painful, really needs to be addressed. The pain element of it, the initial acute fracture, of course, is painful because you've exposed the nerve, you've disrupted the blood supply. Over time, that dulls, but then the next pain occurs when you start to get the necrotic pulp. The pulp inside that tooth goes necrotic and increases its pressure inside, eventually leading to an abscess, and that's really uncomfortable. I've had a lot of human clients who've extrapolated their discomfort from having a broken tooth and a tooth root abscess, and it's not very hard to convince them that their dog or their cat requires dental work if they have a fractured tooth. And this dog here, you can see, I like this photo because you can actually see how much of this canine fractured off. So this could be easily missed if you're not looking in the mouth thoroughly enough. But you can see that the canine on the other side in the background just shows you the outline of what's missing. Feline tooth resorption. So this is the third condition I thought I'd mention because feline tooth resorption, I've personally found, is a lot of the reason why a lot of vets perhaps don't enjoy cat dentals. You know, cats can be fiddly at the best of times with their teeth, but, you know, feline tooth resorption, it's incredibly common, and it's a worldwide issue. You know, there have been studies that have shown upwards and greater than 50% of cats over the age of 3 are affected, and this is really uncomfortable for cats. I sort of, to put it in perspective for my clients, I sort of tell them it's like having a cavity times 1,000. You know, these are the cats that when you have them under an anesthetic and you probe these teeth, even with a nerve block, and they still chatter their jaw and show discomfort. It's sore. We don't really understand the cause of these very well, but there's some theories being thrown around about whether it's an autoimmune response, whether the immune system is attacking the enamel on the teeth. There's been some associations with calicivirus, and also with metabolic imbalances, calcium regulation, interfering with enamel development and bone breakdown. The only treatment option if you find a resorptive lesion is to extract the tooth. In the past, people have tried to do restorative work, trying to basically patch them over, but it's progressive. You cannot, eventually the tooth is going to have to go. And I've put here, dental radiography is essential, and it absolutely is, and I'll tell you why. So here's just a look-see of what it looks like grossly and what it looks like on radiograph. So this is a cat's left lower canine tooth, and this little lesion here, this is, we refer to them as many different things, resorptive lesions, feline odontoclastic resorptive lesions are what we used to call them, a neck lesion, meaning it's, on the neck of a tooth. But this is basically what's happened, for some reason the process has occurred, it's eaten away the enamel. The gum tissue, what it does is it's almost like it comes to the rescue and it grows up over the lesion to try to cover it. But it's invariably painful. And then when we go and x-ray that tooth, this is why x-rays are so incredibly important. In this x-ray, without going into too much detail, you can see the difference between the two canines. So, when looking at the x-ray, the left lower canine, as we flip the radiograph, this is the affected tooth, and this is the one that's unaffected. This tooth root it's effectively ankylosed, so it's fused to the jawbone. And so a viable treatment option for that tooth is actually to do a procedure called a crown amputation, which, compared to trying to extract the tooth full crown and root versus a crown amputation, crown amputation is going to take you 5 minutes. If you try to dig that root out, you could take hours and run the risk of fracturing that cat's jaw. So radiograph's incredibly important. This is just another visual for you, so you can recognize what these resorptive lesions look like. And this is showing this poor cat's got 2 lesions here. This tooth down here is invariably the most common tooth to be affected first, and it's been well documented. So this is your mandibular second premolar. There's no such thing as a first premolar in a cat. And so, you find one here, I think in the next slide, I talk about, yeah, so if there's one lesion visible, absolutely full mouth dental radiographs are warranted, because there's a 70% chance you're going to find more, and they might be subgingival, they might be under the gum line, and there is some evidence that if the lesions are well under the gum line, they can be left and be monitored annually. They haven't been found to be as painful, but once they reach the surface, they're absolutely very painful and they need to be treated. There are 3 types, just as everything else in veterinary medicine. We like to categorize things into different tables and charts and things, but there are 3 types of resorption, quite simply put, based on your radiographic findings. And this is more pedantics for helping you with record keeping. So, a type 1 resorption is essentially you've got the enamel on the crown, and part of the root has been eaten away, but you still have roots in place. And this means that you do have to go in and you need to extract everything. So you need to get the crown as well as the roots out. Type 2 resorption, this is where you can see clearly you've got the crown has been eaten away, you've got the resorption happening at the furcation, and your roots here have basically blurred themselves away. They've ankylosed to the bone. The periodontal ligament, on these teeth, you can appreciate there's a nice dark line going around them all the way. You can't appreciate a periodontal ligament on your x-ray. And this is an acceptable case for crown amputation. You basically raise a little gingival flap, and with your high-speed burr, you just cut right there and suture it over, and you're done. And it saves a lot of heartache, a lot of blood, sweat, and tears, because you don't have to do much. You just need to remove that painful crown because it's so sore. The type 3 only applies to multi-rooted teeth, and this is just to show you that you can get this type where one root can ankylose, and one can be normal. And so radiographs will tell you, cool, okay, get in there, definitely get the crown off, but you will have to get that root out, pardon me, and you can leave that root behind because it's already halfway there, it's already resorbed. The last thing I'm going to talk about, we're almost done, and I apologize because this stops a bit abruptly, but oral masses, this is another thing to look for in your clinical exam, which you may or may not be able to appreciate fully with the animal awake, but good to have a good look. So the most common benign growths in the mouth, the epulae, which we know and love, and they're benign, they're usually smooth and discreet, and it's generally the pathophysiology is that the gums have been irritated by bacteria and become inflamed. Gingival hyperplasia can be the same story, so that's when your gums basically go berserk, they bubble out basically and enlarge, and that can be due to inflammatory disease, or it can be due to extraneous causes such as certain medications can do it. Certain breeds, for example, boxers get this very commonly, so there can be breed predilections. Benign but locally invasive, the acanthomatous epulae, they're not cancer, but they can eat away the local tissues quite aggressively, so they do need to be surgically removed quite aggressively. POF, which is a peripheral odontogenic fibroma, again, benign, but can be quite locally invasive. Malignant, you get into your melanomas, squamous cell carcinomas, osteosarcomas. Basically, the message at the end of this is if you pick up any sort of abnormality, if it looks like a growth, you really, at the end of the day, can't look at an oral mass and go, oh, it's this, just leave it. A biopsy is always going to be prudent, and I'll show you why, and this is my very last slide. These are cases we've seen, and just looking at these, you're not going to be able to look at these and go, oh, it's that. But, this was osteosarcoma, which is an unusual place for it to show up in the mouth. Normally we see it in the rostral part of the mouth. So that was quite sad. That was quite a nasty one. This was a melanoma going across the dog's palate. It looked like an epulae on the outside, and the dog wasn't awake. It wasn't amenable to having its mouth open. So once it was asleep, this caught us by surprise, and it extended all the way across the palate. This is a boxer, classic boxer. So this is gingival hyperplasia. So even though it looks nasty, you know, you can do a gingivectomy on these and remove all that overgrown tissue and treat the periodontal disease. And it can actually look quite nice when you're done, and it's benign. And then finally, you know, this is a cat with squamous cell carcinoma, you know, and it had really nasty breath, and it was really uncomfortable and sore. And yeah, so it's really, really important to recognize that. Yeah, so that's pretty much it. I sort of stopped abruptly there, but just a few references, and you guys can refer back to, hopefully, and access this at a later time if you want to check these out. If you want to get more detail on anything. I sort of breezed over it a little bit. And that's it. So thanks for listening in. And if you have any questions or anything, I think now's the time, isn't it?
Absolutely. Thanks, Marcella. That's awesome. I just love this picture. I'm so jealous that you
this is a crowning achievement in my life.
Yeah, for some context for those who don't know, our clinic does a small amount of work for the local zoo. So Marcella got to go and do lion dentistry, which is pretty cool.
That's pretty awesome.
So I think, thank you so much, Marcella.
Right.
I think we've got just one question so far, but I think that quite often we start with one and then they come flooding in. So Annie has asked, do we deal with lesions in the tooth beneath the crown when the crown seems okay? And when biopsy is not applicable, can FNA work in oral masses? So that's two quite separate questions there. Does that one make sense?
So the first one, are we talking about resorptive lesions or just lesions in general?
Annie, do you want to clarify the question?
Yes, I was thinking, asking about the tooth resorption.
Right.
Yeah.
So if there's evidence so far has shown that if the resorption lay below the gum line, like we're talking around the root apex, you can leave and monitor those teeth. They haven't been shown to be painful as such. But if it's sitting, you know, 3/4 of the way up the root or just about to make it to the gum line, you know, those are the teeth that are at risk of actually breaking off. And so you're better off to address it. Basically, if you're ever in question, get it out.
And I think it doesn't count if the gum's growing up the resorptive lesion. Right? It doesn't make it below the gum.
No, definitely not. No, when the gums are growing up like that, that's a pathologic process, and that needs to be treated. And it's very painful. Yeah. Sorry, remind me what the second question was.
And then the next question was about using fine needle aspirate for oral masses, whether that's a viable or useful alternative to a biopsy.
Well, I would say your animal's going to be asleep. I mean, you're certainly not going to be doing a fine needle aspirate in an awake animal in their mouth. So you're far better to just get a chunk of tissue. A lot of oral masses don't exfoliate their cells very well. And so you've got your animal asleep, you might as well take a chunk. I have had success with osteosarcoma using a large gauge needle and taking, you know, fine needle aspirate, but it was effectively like a core biopsy. But yeah, I would say you're far better to take a biopsy. Is it more like for financial purposes or, you know, availability of resources?
Yeah, sometimes the owners, they don't agree to do biopsies, or sometimes we don't have like suitable labs. So
suitable labs.
Yeah.
I mean, I guess that's tough. It's if that's the case, then certainly try. You can try a fine needle aspirate. You can try to do some in-house cytology if you've got someone that's a gun with, you know, they're good at cytology. Worth a try. But I think it's the same with, you know, any other lumps anywhere else in the body. You know, there's limitations to fine needle aspirate, and as long as you explain that to the owners, you know, what I often will do is if I've got an owner that's, you know, financially strapped or they don't agree to biopsy, I'll still take a chunk and just sit it on the shelf in some formalin. And then if there's problems down the line, you've got that tissue there to work with later as well.
I think it'd be super important too if you were going to go down that FNA route to manage the client's expectations of getting a useful answer. If they decline your recommendation for a incisional biopsy and would prefer the needle aspirate, you need to make sure they know that that might not give the answer. Absolutely. So that at least if it doesn't, then you don't look silly. You've already explained that to them. Is that something that's done in China, that you sample tissue and then hold it in case you need it, or do you guys do that much? We do it a lot.
Yeah, sometimes we do that, but sometimes we sometimes the owners, they will ask questions. So it depends.
Yeah, I think it's always useful if I always try to remember. I'll just take it, and then if we need it later. It depends what the barrier is, doesn't it, for that individual owner?
Absolutely.
Yeah.
Cool. Is that it?
Yeah, it might be. Come on, we need some more questions. Might not be any.
Oh, that's okay. Hopefully everybody didn't fall asleep.
It was obviously such a good talk that you explained everything. That nobody has any questions.
So. I'm not used to talking at 1 a.m, so this is a new one for me. No, it's good.
So, here we go. Here's another one. Annie, you might have to do that one because that one's come through in Chinese.
Yes. Yes. So this question is, how do we recognize the type 2 teeth resorption? Do we have more information on that?
How do we recognize
the type 2 teeth resorption? So it's a feline tooth resorption.
How do you recognize the type 2?
Yes, type 2.
Oh, the type 2. So the only way you can recognize type 2 is with an X-ray.
Okay.
And so if we refer back to the slide, let me find it. When you look at the normal tooth on an X-ray, you will see this dark line going around the root all the way around. That's your periodontal ligament. So with type 2, I think it was pretty, let me show you this one. In the type, so this one's a type 2. This canine, it's quite fuzzy. You can't appreciate the dark line, whereas you see on this one, you can see this nice dark line going around the other tooth to kind of use as a comparison. So and if you're ever in question about it, there hopefully, I'm not sure what resources are like, but they're, with the advent of email and all the technology, you can always email images to someone with a specific dental interest. Or I don't know in China what sort of dental specialists are over there, but it's always good to reach out if you don't know, and you take an image and you're not too sure. You're better off leave it, ask somebody, and then you can figure it out that way too. But
I think before dental radiography was something that we always did, these teeth could be an absolute nightmare to extract.
And that's the message I wanted to kind of get across with this, is that it's you can save yourself a lot of blood, sweat, and tears by taking an X-ray, and of course it's knowing how to take the X-ray and then knowing how to interpret the X-ray, but my goodness, it can save you a lot of heartache if you do it, because you can, and also it a shorter anesthetic for your patient.
And less traumatic procedure, less expense for the client overall, probably.
Exactly. And make people enjoy cat dentals. They're not that bad.
Does that answer the question, Annie? Can you check with, I can't see who it was who asked.
Yeah, that's from Dr. 段。段医生，那个他们问说，这样有没有回答您的问题？ Yeah, Dr. Duan says it's okay.
Does he have dental radiography in his practice, Annie?
Yes, yeah, he does.
Yeah, so if certainly for our trainers who are listening, and if there's anybody who wants some help with figuring this out, if you're not used to doing it and you do have dental radiography, I'm happy to help you. I'll probably have to ask Marcella.
Yeah, no, that'd be great. No, I'm more than happy to help.
For our trainers in particular, just message me on our WeChat group, and I can help you learn how to tell the difference so that you know which teeth you can do crown amputations on. So another question from Annie, for feline stomatitis, this is such a big subject, how can we do a full mouth extraction or half mouth extraction, and does it depend on the teeth?
Sorry, say the first part of that again. I cut out.
So for feline stomatitis,
yeah,
how can we judge whether to perform full mouth or half mouth extractions, and does it depend on the teeth?
So with stomatitis, I mean, you can, when you've gotten to the point where you need to go to full mouth extraction, caudal extractions has fallen out of favor, meaning you extract from the premolars back and leave the front of the mouth. In some cats, and case selection is so important because, you know, it depends on, you know, owner finances and lifestyle and management. You know, you can, in some cats, if there's absolutely no gingivitis or periodontal disease on those canines, you can start with caudal extractions, but invariably it's going to progress to requiring full mouth extractions. If we think about the pathophysiology of stomatitis, is effectively your cat is having a hyperimmune response to plaque on the teeth. So the purpose of the full mouth extraction is effectively to remove the plaque retentive surfaces in the mouth, as well as all of the periodontal tissues. Again, it's like resorption in that we don't fully understand every little step of the way, but what they've correlated the disease with is the presence of plaque, and they've correlated with the presence of periodontal tissues. So, you know, when you're doing the full mouth extractions as well, you need to remove the periodontal ligament and the surrounding alveolar bone. So it's quite drastic. So in short, you're better to do full mouth extractions rather than sort of muck around and just take a few out. And I will often stage them because it's a lot to put them through. You know, these cats it's sore. So, you know, if you, often I'll do one side and then a month later I'll do the other side, top and bottom kind of thing. But again, it's case by case. If you've got a cat that's only got a few teeth left anyways, you'll get it done in one hit. But if you've got a cat with full dentition, I would tend to recommend staging it.
Annie, do you think that you can, was Peter translating that, or no?
Yes, I was. Yes, I was.
Oh, you were?
Oh, cool.
Right, we don't need to get Annie to do it.
Okay,
Thanks, Peter.
good.
But Annie, if you could also rephrase it if you think my translation isn't accurate enough.
Oh, yeah.
I'm sure it was.
Did it make sense?
Yeah, no, it made sense to me.
Yeah, I know. I just want to make sure. Yeah.
Great. Okay, they were some good questions there.
Yeah, really good.
Raising some other, you know, some really important practical things that we come across. So that's good. Cool. Anybody else have any questions, or shall we wrap it up? Again, for our trainers, if anybody comes up with anything after the webinar, I'm happy to liaise any of your questions between myself and Marcella and get back to you. Mm-hmm. You know, sometimes I know when you finish a webinar, you come up with questions afterwards.
Yeah.
I should have asked about this.
Oh, yeah, that.
Oh, yeah. Great. Okay. I guess all that remains then is to thank Dr. Marcella so much for your time. As always with these webinars, I think I probably learn just as much as our Chinese vets do, because they're usually subjects I should be more up to date with than I am. So that was great. I really enjoyed it so much. And if you don't mind, Marcella, just stopping your screen sharing for a wee second,
Yes.
I will pop up the QR code if I can. Annie, is that last one there another question, or is that's just come up on the chat?
No, that's
That's
That's your thank you.
You're welcome.
thank you.
You're welcome.
So I'm just popping up this QR code here for everybody to see. If you don't mind clicking through to that so that you can complete our short survey on what you thought of tonight's webinar. And our last one for 2020 will be coming up on the 13th of November. We've got Dr. Richard Lucy, who's a postgrad qualified in both cardiology and diagnostic imaging, and he's also a human ultrasonographer, so some pretty amazing skills there. And he's going to talk to us about differentiating cardiac from respiratory cases in coughing patients, which is certainly something that I struggle with sometimes in general practice. What tools that we can use to try to easily differentiate between cardiac and respiratory disease in the coughing patient, and even not necessarily with a lot of fancy diagnostics. So that should be really good. We'll share more details about that soon. One more message on the chat there. Just more people saying thank you, which is lovely.
You're welcome.
So I think that's it, everybody. Thank you so much, Marcella, and thanks everybody for coming. And hopefully we'll see you all again on the 13th of November.
Bye.
Bye. Thank you.
It's all right.